Free Rehab, which is also an online educational platform, and I am faculty at the University of Southern California. I also have a wife and 2 dogs that you can see in the picture there. So this is going to be spread into 4 different modules. The first module is focusing on the anatomy and function of the ankle and foot. The second module is going to be looking at a lot of the common diagnoses. The third module is based on the assessment of those diagnoses. And then the fourth module, we're going to look at management of those conditions. So let's start with the anatomy and function of the ankle and foot. So just to define some movements here, when we're looking at sagittal plane movement, we're really thinking about dorsiflexion and plantar flexion for the ankle, maybe for the toes, flexion and extension. But we're thinking about a mediolateral axis of rotation. It's easy to think about it for the shoulder. Frontal plane, as opposed to the shoulder, where we're looking at abduction and adduction, we're thinking about eversion and inversion. And that's going to have an anterior to posterior axis of rotation. You might also see the words varus and valgus as it relates to postures or positions of the foot, and that's also going to be related to the frontal plane. The transverse plane, we're actually calling that abduction and adduction, and that's going to have a superior to inferior axis of rotation, right? So in the shoulder, we would call that external and internal rotation, and we'll actually see that at the talus, we'll also refer to this movement as internal and external rotation, but oftentimes it's abduction and adduction in that transverse plane. So we can see the movements here, that top left picture, abduction and adduction of the foot, plantar flexion and dorsiflexion, that frontal plane eversion and inversion, and then there's 2 pictures of that. For supination and pronation, supination is just a combination of plantar flexion, inversion and adduction, and pronation is a combination of dorsiflexion, eversion and abduction. We'll see that the joints of the ankle and foot aren't in these pure planes of motion where they're only moving through plantar flexion and dorsiflexion or inversion and eversion. There's going to be a combination of these movements occurring. So we're actually going to start by looking at the distal tibiofibular joint. This is what we often refer to as maybe the high ankle, right? It's not actually the ankle joint. We'll talk about that, the talocrural joint, but it's important when discussing the ankle. So it's a syndesmosis joint. It has 3 primary ligaments. You might see different references in the literature. This is how I'm going to describe them for simplicity. There is the anterior inferior tibiofibular ligament, the posterior inferior tibiofibular ligament, and then the interosseous tibiofibular ligament. So we have that picture on the right. On the left, we have kind of an anterior oblique view, and then the picture further on the right is a posterior view of this distal tibiofibular joint. So these are just some pictures, so drawings and then actual dissections of the anterior inferior tibiofibular ligament. You can see it spanning that distal tibia and fibula, especially on that zoomed in picture on the right. Now we're going to be looking at the foot and ankle from a posterior view to appreciate that posterior inferior tibiofibular ligament. And once again, we have the kind of drawing or that rendering of it, as well as those dissections. And then we have the interosseous tibiofibular ligament. This is actually an extension of that interosseous membrane that would span between the tibia and fibula. These images are just showing where this ligament would occur. This fibula is separated away from the tibia in this picture. And all of these ligaments are just adding to stability of this joint. There's not going to be a lot of movement here, and we will talk about the movement that does occur. So the talocrural joint is generally the joint that we're thinking about when we say the ankle joint. It's a hinge joint, and then these are the main ligaments that we're going to be thinking about. So talocrural joint, articulation between that tibia, fibula, and the talus. So although it's a hinge joint, and we think about it moving into plantar flexion and dorsiflexion, and I have a model here, we can see that it doesn't have, a pure medial lateral axis of rotation, or it would be pure plantar flexion and dorsiflexion. So as I mentioned earlier, that dorsiflexion is going to have a combination of abduction and eversion, and plantar flexion, adduction and inversion, although generally we're thinking about this joint contributing to plantar flexion and dorsiflexion. One other thing to mention about the talus is that it's wider anteriorly than it is posteriorly. So as it relates to that distal tibiofibular joint, that syndesmosis joint, when you go into your end range dorsiflexion, to accommodate that wider anterior talus, that tibia and fibula have to splay just a little bit to allow for that motion. And we'll see why that's relevant later on. In terms of the ligaments, that top right picture, we're looking at the medial aspect of a right ankle, looking at what's globally called deltoid ligament. It's actually 4 ligaments, so the anterior tibiotalar, tibionavicular, tibiocalcaneal, and posterior tibiotalar. And then we have the lateral ligaments, anterior talofibular, calcaneofibular, and posterior talofibular ligaments. As it relates to the foot, usually we think about the foot in 3 sections. So we have the rear foot or hind foot, which is the talus and calcaneus, the midfoot, which is the navicular, cuboid, and 3 cuneiforms, and then the forefoot, which is the metatarsals and phalanges. So the subtalar joint, this picture on the left, this talus has been picked up and kind of moved over to show its articulation with the facets of the calcaneus, but also you can see it articulating anteriorly with the navicular. And then on the right there, we have a picture where the calcaneus was kind of moved over so we can appreciate the calcaneus as it relates to the talus. So subtalar joint articulation between that talus and calcaneus. One landmark to kind of look at on the calcaneus on that bottom right picture is that sustentaculum tali, which we can see on this bony model as well, which just kind of acts as a shelf for this talus to sit on. In terms of the subtalar joint motion, the pictures on the right are just showing the axes of rotation for the subtalar joint and showing the variability there. But for non-weight-bearing pronation, we're describing the calcaneus moving relative to the talus. So it's moving into eversion, abduction, and dorsiflexion. And in non-weight-bearing supination, it's inversion, adduction, and plantar flexion. Now, oftentimes we are referencing weight-bearing, and we actually reference the talus moving on the calcaneus for the sagittal plane and transverse plane. So for weight-bearing pronation, the talus would be moving into adduction and plantar flexion, and for weight-bearing supination, the talus would be moving into abduction and dorsiflexion. And once again, internal and external rotation are going to be synonymous with that abduction and adduction for the talus there. The sinus tarsi is just the space between the calcaneus and talus there. So we're looking at this space right in here. Picture on the right, it has some the ligaments labeled there. So number 10, the talocalcaneal interosseous ligament, and 11 is the cervical ligament. So those ligaments are adding stability to that subtalar joint. The transverse tarsal joint, or joints, also referred to as the mid-tarsal joint, is actually two joints. So it's the calcaneocuboid and talonavicular joints. They connect the rear foot with the midfoot. And once again, they're going to have this combined pronation and supination movement. And we're going to talk about these as they relate to gait. So for loading response and mid-stance, the subtalar joint is going to be pronating. That transverse tarsal joint, or that mid-tarsal joint, so going back, calcaneocuboid and talonavicular joint, they're going to be unlocking at this time, and that's going to help create a compliant midfoot that's adaptable and helpful for shock absorption. Okay, so that's the loading response and mid-stance. For terminal stance, the subtalar joint is supinating. That transverse tarsal joint is locking, and that's going to allow for a stiff midfoot. Okay, so we want our foot to be adaptable and have different functions depending on what we're trying to accomplish, right? So during that loading response, mid-stance, we want it to be a little bit more of a shock absorber, a little bit more compliant, versus this terminal stance, we want it to be stiffer. And this applies not only to gait, but to running and to sports and to all different activities that we do. But it's just highlighting kind of that relationship there between that subtalar joint and that transverse tarsal joint. Sometimes, in weight bearing, pronation is simplified as lowering of the navicular and arch, and supination is the raising of the navicular and arch. And I'm fine with that too. It's a nice simplified way to maybe describe that to patients or others. One thing to note in terms of combined motion, so with that pronation and lowering of the navicular and arch, I mentioned that the talus adducts in weight bearing. Okay, that adduction is also internal rotation. And there's going to be a coupled motion between the talus and the tibia because of that close articulation. Right? There's not a lot of transverse plane movement allowed here. We saw that it does mostly sagittal plane movement. So if that talus is internally rotating, that tibia is also going to be internally rotating. So it has that combined motion. And we can drive that. We can think about it being driven either bottom up or top down, right? That tibia internally rotating, that talus adducting or internally rotating as well. Other joints of the foot, the tarso-metatarsal joint and the metatarsophalangeal joints. So tarso-metatarsal is just relating to the cuboid and cuneiforms articulating with the metatarsals, and then the metatarsophalangeal joints, those metatarsals articulating with the phalanges. And this is going to be important because we're going to talk about Liz Frank injuries, which relates to this tarso-metatarsal joint, and then some injuries of the metatarsophalangeal joints. This is also showing this capsulo-ligamentous complex on the right. We're not going to go into too much detail of that, but you can just appreciate some of the complexities there. Muscles of the ankle and foot can be kind of simply categorized as being intrinsic or extrinsic, right? Intrinsic muscles are muscles that are originating and inserting in the foot, so they're only attaching within the foot. Extrinsic refers to muscles that are originating outside the foot, right? But they do have an attachment in the foot. And those are the ones that we're going to be focusing on because they're also crossing that ankle joint and having actions at that ankle joint. So we can split it up into anterior, lateral, and posterior compartments for those extrinsic muscles. So for the posterior compartment, there's a superficial layer and a deep layer. The superficial layer is going to have the gastrocnemius, and it has medial and lateral heads, the soleus and the plantaris. And then the deep layer is going to have the tibialis posterior, the flexor digitorum longus, and the flexor hallucis longus. All of these muscles are innervated by the tibial nerve, and all of these muscles are plantar flexors and inverters. So it's an easy way to think about them. So everything in this posterior compartment is going to plantar flex and invert. Now, some of these muscles are going to have some other actions, right? The gastrocnemius crosses the knee. It's going to have a small flexion component at the knee. The flexor digitorum longus is also going to have a flexion action at the toes, and the flexor hallucis longus is going to act at that big toe, right? But this is a way to simplify some of these muscles here. Now we also have the anterior and lateral compartments. The anterior compartment, tibialis anterior, extensor digitorum longus, and the extensor hallucis longus, all of these muscles are innervated by the deep peroneal nerve, and they're all dorsiflexors. Now, in terms of inversion and eversion, they have some different actions. So the tibialis anterior is an inverter, the extensor digitorum longus is an everter, and then the extensor hallucis longus can be both because it sits right on that subtalar joint axis of rotation, so it can act as either one depending on the position of the ankle. And then once again, other actions, right? The extensor digitorum longus, you're thinking about extension of those toes. Extensor hallucis longus, thinking about extension of that first toe. The lateral compartment, peroneus longus and peroneus brevis. Superficial peroneal nerve is the innervation there, and they're plantar flexors and everters. This image is a nice way to help simplify some of the muscle actions of the ankle and foot as well. We have 4 quadrants, and depending on what quadrants the muscles are sitting in, those are the actions that they're going to be contributing to. So for example, the tibialis anterior and the extensor hallucis longus are sitting in this upper left quadrant here, dorsiflexion and inversion. And that's because they're sitting in front of that talocrural joint axis of rotation and medial to that subtalar joint axis of rotation. So based on their line of pull relative to those axes of rotation, those are their muscle actions, right? We can see plantar flexion and inversion there, tibialis posterior, flexor digitorum longus, flexor hallucis longus, the Achilles tendon, and then we can see the other quadrants. I didn't mention the peroneus tertius. It's kind of an extension off of the extensor digitorum longus, so it also sits in that dorsiflexion and eversion quadrant there. We're also going to talk about nerves briefly because we're going to come back to them for the diagnoses and assessment. If we start with the picture on the left, I've created a schematic of the nerves of the lower extremity. So starting with the sciatic nerve, which is traveling in the posterior thigh region, and then at the level of the distal posterior thigh, it splits into the tibial and common peroneal nerves. The tibial nerve stays posterior all the way down the leg. It's going to travel in that tarsal tunnel, which is that area posterior to the medial malleolus. And then at the foot, it splits on the plantar aspect of the foot into medial and lateral plantar nerves. The common peroneal nerve kind of wraps around that fibular head, that fibular neck, and that splits into the superficial and deep peroneal nerves. And the superficial one is lateral in that lateral compartment, and that deep one is in that anterior compartment. Then you can also see the cervical nerve, which is just a branch that comes off of both the tibial and common peroneal, and that's kind of a posterior lateral cutaneous nerve there. So just a little bit of a schematic to simplify, the nerves of the lower extremity. The picture on the right is another quadrant of these nerves as it relates to where they travel, but also how we might bias them, during some of our sensitizing maneuvers to assess for nerve mechanosensitivity. So in the upper left quadrant, we have the saphenous nerve because it's on the medial aspect of the ankle and anterior to, that kind of talocrural joint axis of rotation. And so to bias that, SEP would mean that S for saphenous, E, to bias it, to put tension on it, you would put it into eversion, and then P, plantar flexion, okay? And the saphenous nerve is actually a branch off of the femoral nerve, so that's why you don't see it in the schematic here. That femoral nerve is going to be an anterior nerve. The bottom left quadrant, the tibial nerve, TED, to bias that, you would put it into eversion and dorsiflexion, the ankle and foot there. The peroneal nerve, you would put into plantar flexion and inversion, PIP. And then the sural nerve, you would put into inversion and dorsiflexion. Okay, so the nerves are in the quadrants, in the areas that they run, but the letters relate to how you would stretch them as opposed to the last one, which is the muscle actions of those muscles. And then last here is just kind of a mapping of the sensory innervation of the ankle and foot. So as I mentioned, tibial nerve gives way to medial and lateral plantar nerves, and we can see that on the right, that orange and pink colors. Common peroneal nerves gives way to the superficial peroneal and deep peroneal nerve, and we can see that on the dorsal aspect there in gray and orange. And so you can see that deep peroneal nerve is just really that first web space. The saphenous nerve, which is coming off of that femoral nerve, we can see in yellow in both the dorsal and plantar views. And then the tibial and common peroneal nerves give branches to create that sural nerve, and then we can see that slight green there. The last thing I want to mention in this module is don't sweat the small stuff. We're going to use this information to drive discussions in the later modules, and hopefully I was able to simplify some aspects of the anatomy and function of the foot and ankle for you, but just know that you don't have to be an expert in this material and have every little thing memorized in order to help your patients. That's not what makes a good physical therapist.